This video provides an overview of shock in the context of Advanced Trauma Life Support, or ATLS. This video is based on the 10th edition of the Advanced Trauma Life Support Guidelines. In this video, we will define shock, identify its primary causes, discuss clinical signs, and review management protocols, including specific considerations for special patient populations. Shock is defined as an abnormality of the circulatory system that leads to inadequate organ perfusion and tissue oxygenation. Understanding cardiac output, which is the product of heart rate and stroke volume, is essential for grasping the pathophysiology involved. The body compensates for blood loss through vasoconstriction to protect vital organs. Tachycardia is the earliest measurable sign. Inadequate perfusion forces a shift to anaerobic metabolism, resulting in metabolic acidosis. Notably, vasopressors are not the first-line treatment for hemorrhagic shock. The golden rule in trauma is that any cool tachycardic patient is in shock until proven otherwise. Do not rely solely on blood pressure, as compensatory mechanisms can maintain it until 30% of blood volume is lost. Assess pulse, respiratory rate, and skin perfusion instead. Hemorrhagic shock is the most common cause of shock in trauma. Other categories include cardiogenic, obstructive, neurogenic, and septic shock, each with distinct underlying mechanisms ranging from blunt cardiac injury to loss of sympathetic tone. Hemorrhage is classified into 4 classes based on the percentage of blood volume lost, ranging from Class 1, which is less than 15%, to Class 4, which exceeds 40% and constitutes a severe pre-terminal event. This table summarizes the signs and symptoms of hemorrhage by class, detailing how heart rate, blood pressure, and other parameters change as the severity of blood loss increases. Initial management follows ABCDE priorities: ensuring airway and breathing, controlling external bleeding, checking neurological status, and preventing hypothermia. Vascular access should be established with 2 large-caliber peripheral lines. For fluid resuscitation, start with a bolus of warmed isotonic crystalloid. Use a strategy of controlled or permissive hypotension to avoid worsening hemorrhage before surgical control. Monitor urine output to assess the adequacy of your resuscitation efforts. Patient response to initial fluid resuscitation can be categorized as rapid, transient, or minimal to none, which helps guide the need for further blood products and urgent operative intervention. The goal of blood replacement is to restore oxygen carrying capacity. A massive transfusion is defined by specific unit thresholds over set timeframes. A balanced ratio of blood products is essential to prevent coagulopathy, and all fluids must be warm to prevent hypothermia. When assessing patients, be aware of pitfalls. The elderly may have limited reserve, athletes may mask shock until sudden collapse, and pregnancy can hide signs of maternal shock. Furthermore, patients with pacemakers may lack a tachycardic response to volume loss. Thank you for watching. Study, reflect, and improve your practice.